Okay, well, welcome everyone to our scope session today. We're so excited for you all to be here and excited for the presentation and case presentation we have. We're going to go ahead and get started. So as you heard when you hopped on, we are recording this session, and it's going to be available on YouTube and our Canvas page. And so if you do not want to be recorded, you can go ahead and hop off. And then we've been on Zoom for a while, but if you need to rename your profile or raise your hand, the instructions are right here. And if you do need help or assistance, you can reach out to me or our hub members. They have an asterisk by their name, and they can help walk you through that. And we will be, with that, we will be monitoring the chat. So if you have questions or comments, you can put it in the chat or come on mute and we'll let you talk. And just remember to protect individual privacy. So a lot of information, if we shared about people and families, it's personal information. So just avoid using their name and not identifying family members or individuals. And if you're unsure about something, go ahead and reach out to a hub member. And this Echo is an interactive community, so we really encourage you to turn your camera on and ask questions and make comments, whether it's speaking out loud or commenting in the chat. But we just want to really build that community and get to know each other and collaborate. And with that, the key components of an echo session are those case presentations and that collaboration. So if you, as always, we'll give a plug for case presentations. I think I also will say it in a little bit too. But if you have a kid you're working with or a family and you want to get some new ideas and resources, it's a great way to do that. And so just message me or someone else, another hub member, to if you're interested in that. And there it is. There's more information about the case studies. And if you do want credit for attendance, there is an evaluation and a survey that will be sent out, and I will be putting the link in later in the chat that you can take and fill out, and then we'll give you that certificate. And Canvas is the platform where we put all the slides and resources that are shared and the notes from the case presentations, as well as the recordings. So if you want to be on that Canvas page and you're not, go ahead and email projectscope@usu.edu, and we will make sure to get you added to that. We're going to skip that. And in our social media, it's a great way to see updates and announcements and changes to the schedule, as well as we share a lot of the resources and notes from past presentations. So it's really helpful. So thanks again for attending. And I'm going to go ahead and stop sharing and turn the time over to Kyla. We're so excited for her presentation about like a walk through the foster care system. So.
Hello, my name is Kyla Clark, and I'm going to sit here and pull up my screen. Uh-oh. We just tested this, and it was showing it a second ago. Let's see. Aha. Let's try it now. Maybe. There we go. I can share my presentation. Are you guys seeing my presentation?
Yes.
Beautiful. All right. So my name, like I said, is Kyla Clark. I have worked with DCFS for the past 16 years. I'm going to talk a little bit of overview for DCFS, but mostly would rather have as much of a conversation as possible with you guys about questions with interacting with the system. Just by quick poll in the chat, how many of you have actually worked with a family involved in child welfare? You guys want to put in the comments? Okay. A couple. Many, okay, yeah. Did you know that for any child under the age of 3, if they have a supported CPS case, they are actually given a letter about Baby Watch automatically? That is something that is sent up through our system, where there is an automatic referral, well, information about Baby Watch sent to that family. because we really do want to be collaborative with early intervention as much as possible. I think there's definitely room in our system for improvement on that. I think supported findings of abuse and neglect are part of it. But you'll see through these slides that we don't actually move forward on most of the things that we investigate, or even most of the referral calls that we get. And so the system is always looking for ways to make references to some of the community-based interventions. We are the abuse and neglect agency. That doesn't mean that there isn't like parenting support and parenting need long before parenting decisions become abusive or neglectful. And so as we sit in this awesome opportunity as a community of practice to really kind of plant the seed for envisioning what is a child welfare system that's larger than abuse and neglect. I think sometimes everything child welfare gets shoved into DCFS, but DCFS is really the caboose or the worst case outcome, if anyone wants to be identified as the worst case outcome. But we're really when parenting and parenting skills have really struggled, that's where that abuse and neglect happens, and that's where DCFS lies. And so I really just want to kind of throw my name out there, share my email, and say I'd love to hear ideas that this group of people have about how we really transform it into more of a child welfare, and family supportive system that hopefully intervenes to reduce the need for the child abuse and neglect part of the system. Okay, so there was a soapbox. We'll start with the official mission of Child and Family Services, which is to keep children safe from abuse and neglect and provide domestic violence services by strengthening families and working with communities. The vision of Child and Family Services is safe children and strengthened families. That is what we are attempting to do. Okay, I was moving. There we go. Calls to DCFS begin at that centralized intake. It is a 24/7 hotline. You can remain anonymous when you call in. We do have mandatory reporting laws in the state of Utah, and every one of us on this call is technically a mandatory reporter. So if you are told by a child that they are being abused and neglected in their home, if you're witnessing that abuse and neglect, you are to report to this DCFS hotline, and they will screen the call and decide at what level to respond at that point. So when we talk about what to report, we'll talk a little bit about signs of abuse. From the adult side, you'll see that they're blaming the child. Maybe they're using some harsh discipline. Perhaps they're acting secretively around you or very controlling of the child. Some of it's rejecting a child. In fact, I couldn't figure out a way of getting around the confidentiality of it, but there is a TikTok that's going around of a lady who posted her 11-year-old having a meltdown and calling it sort of reactive attachment. But then when you look at the rest of her TikTok videos, I think she has probably 100 posted. You never ever see the 11-year-olds. You only see her 1-year-old child. That's the only kid that she's interacting with, except for this one tantrum. And so you start to see these like, are we treating maybe one of these children in the home different than we're treating other children? Constantly reporting the child is bad, unable to give you anything positive about their child, their own history of abuse, and being in domestic violence situations. These are all contributing factors that we see to what leads to adults maybe losing that ability to properly parent. Signs of a neglect that we see in adults might be indifference. It could be suffering from their own mental health issues, some deep depression. We see a lot of neglect as a result of substance use. In fact, for the state of Utah, about 73% of all families that are involved in the child welfare system have some caregiver substance use as a contributing factor. Sometimes you see irrational behavior where they just are arguing with you that a 2-year-old can be left home alone. Unrealistic expectations often lead to neglect. And then the child meeting adult needs. So our children stepping up to do sort of parenting pieces because their needs are being neglected. So they might be stepping up to take care of the parent, or they may be stepping up to take care of any of their siblings. Any questions or comments you want to add in on that? Like I said, interactive makes these more fun. Any thoughts on any of those topics? Anything else that you've seen that I haven't mentioned? And you can unmute or throw it in the chat. All right. Well, if you have other ideas, feel free to interrupt me at any time. So the next thing we look at is the signs of abuse in a child. So you'll see injury. Obviously, that's our biggest one. Marks on a child, especially on children that are non-mobile. These are called sentinel injuries, or injuries that don't make sense based on the developmental level of the child. You might see withdrawal, unusual sexual behavior, aggression, dramatic changes in behavior, strain in their relationships, becoming fearful of adults. We often see bedwetting, passivity, suicidal ideation. We also see sort of developmental backsliding. Sometimes we're neglect. We'll hear of children reporting being hungry. We'll see stealing or hoarding behaviors. Non-supervised, we get a lot of these. These are the kids that you see wandering down the street. I think there was one in the news not that long ago, or you know, that I think had wandered into a Walmart alone, about 3 years old. Not clothed for the weather, not bathed, reports of not getting that self-care that they need. This is where we sometimes get in on medical or dental neglect. So things that you might see in the home where it's, if you are doing an intervention that are concerning. Okay. So what we do not respond to is poverty, homelessness, or cultural differences. So sometimes we will get calls because they are worried about, there's a difference between not being addressed appropriately for the weather because I can't afford new clothing versus I'm just not paying attention to the weather today, or because of my addiction, I'm not. We do not automatically take kids into care because they're living in a car or living with homeless parents. We often connect to resources, but that is not a reason for abuse or neglect intervention. Same thing with cultural differences.
Yeah, that's what okay.
So the three things we need to open a case. So sometimes people get frustrated when they call intake because they do not, we may not open a situation. So the three bare minimum things we need is an actual child. So someone under the age of 18 has to be part of the referral as being abused or neglected. You need to have an allegation of abuse, neglect, or dependency. And dependency is a no-fault finding on the parent, but due to the child's own behaviors may need to come into care. This really applies to our teenagers. We do not, it would be extremely rare to have a dependency finding on a child in early intervention age. And then the third and most important is actually a way to locate the child. So if you call us and say, we saw this mom slap her child in the middle of Walmart, but we don't know mom's name, we don't know the child's name, we don't know where they live, we don't have a way to get to Walmart fast enough to intervene in that scenario. So that can be really frustrating. But we don't have a way to find that parent and that child. So just know we have to be able to actually locate the child, and we can locate the child at school. We can locate the child at therapy session. It doesn't have to be necessarily the family home, but we have to have a way to be able to track down that child you're concerned about. All right. Intake will then staff the referral if it meets those three requirements. They will unaccept or accept the referral at that point. If unaccepted, they will document why, they will offer resources, and then they will close the referral. And if you have any questions about our centralized intake or any specific things that you want to follow up on, Marnie Maxwell is my coworker. She is our intake administrator, and this is her contact information, which you guys will have access to with these slides. So if it is accepted and we open a CPS case, which happens at about 20% of all the calls, which sounds like a very small percent, but most of them can be done through community referral, or like I said, we do get a lot of calls where we don't have one of those 3 main criteria, and so we're not able to open a case. Also, we get calls that my former supervisor used to refer to as wonky parenting that isn't necessarily like A+ parenting book, like what you would suggest in a parenting class. However, it does not cross the line into abuse and neglect. And this is where that broader child welfare system, where your guys' agencies and your interventions are way better suited than abuse and neglect investigations coming in and looking at it. So anything that's a priority 1 has 1 hour to respond. Priority 1s are incredibly rare. So if CPS gets a priority 1, those typically are like kids immediately in the emergency room, or if I have 2 caregivers being arrested and the kid has nowhere to go. Priority 2 is within 24 hours. That is going to be most of our kid with bruises, concerns about being left home alone. Those are going to be your priority 2. And your priority 3 are going to be 3 business days, 3 working days. And that might be your things like kids not attending school, or we have some concerns about substance use, but the kids are currently safe. An investigation will need to see the child first. They will always interview the child before they interview the parents. And this is done because we want to make sure that they get a clean interview with the children before a parent might have a chance to tell the children what to say to us. So this is why you see CPS investigations happening in schools. They have to, once they have talked to the child, they have to interview the parent that same day. They have to make contact with the parent. They may not actually get the formal face-to-face interview, depending on what the parent has going on, but they do have to inform the parent that they spoke to the child as soon as that child interview is done. And then they will interview whoever the allegation is against, or the alleged perpetrator of the incident. They will do an unscheduled or unannounced visit to the home. And then they will interview collateral contacts, which often includes whoever the referent was. And then we have a validated safety and risk assessment tool that will be completed. And the total time frame a CPS case can take is 30 days without applying for an extension. Sometimes situations are complex enough that we do need to extend beyond 30 days. Sometimes they are clear-cut enough that a case is going to be open and closed within a couple of weeks. Any questions or concerns on that? Quiet group. I'm hoping everyone's getting some lunch. Okay. So we look at what's going on, threats of harm, vulnerability of the child, protective capacities, and then what is the current situation? What are the parents' capacities? What is the history? And do we need ongoing services? So the safety assessment is going to tell us whether we can create a safety plan, whether the child is safe or whether the child needs to be removed. And then our risk assessment is determining what kind of services we need to go ongoing. Like, do we need to open an ongoing case? So sometimes we won't find enough evidence during a CPS investigation. So there are 4 possible findings: without unsupported, without merit, unable to locate, or false report. Without merit and false report are 2 that are not very common. Without merit means that we genuinely go out and we say, nope, this might be your mother-in-law just really doesn't like the way you parent, but there's not a problem. So it's without merit. False report can actually be criminally charged. So that is when you are maliciously using DCFS. Occasionally this will happen in some of our maybe uglier divorce scenarios. We do not make this finding lightly because, again, it can be used to file criminal charges. But we have seen people kind of use DCFS as a punishment thing, where we're getting calls that are completely unbased, just to harass someone. So you cannot use us to harass your neighbor that you do not like. That's the takeaway from false report. If we do not open a case, like we said, we do try to link to community resources, and our DCFS involvement will end at that unsupported point. If we do create a safety plan, we will offer 2 types of ongoing service. We have collaborative services, which means there is no court involvement, but DCFS will still help pay for services. We will still create a service plan. We will put interventions into the home, and you will have a case manager. Or we have our protective supervision services, which are court-ordered in-home services, where the child will be appointed a guardian ad litem, and there will be quarterly court hearings, and also those same kind of services. Contracting for the services looks the same, whether it's a collaborative or a PSS case. Typically, the difference is the severity of what's going on in the home and the parents' acknowledgement, readiness to change. If the parents really, like, by the time DCFS gets there, is like, we've been looking for help, we really do know that we need to do these things, we may start out as collaborative. DCFS's philosophy is least intrusive as possible. So if the family's really willing and really open and really workable, we could do collaborative. Some of the higher risk scenarios, the judiciary system likes to have an eye on, just as an extra layer of support. Drug cases tend to need to go PSS unless we're talking about maybe misuse of prescription medication. And THC is in some weird gray area with some unique legislation around it. So those often are seen as collaborative cases. Questions on that? I feel like I'm talking really fast. Okay.
I think you're doing great, Kyla. I love it.
Awesome. All right. Well, encouragement, I'm moving on. So just that overview from the year 2020, we do need to update this. We do these polls about every 2 years, so I should have 2022 data soon. But 40,367 calls went to our centralized intake. 20,000 were accepted for CPS, so a little over half. 7,000 resulted in confirmed abuse or neglect. 5,000 of those received in-home services. And then the remainder went into care, and 1,900 of those were served in a kinship placement. And when we say kinship placement, that's a relative or friend placement. And then there's a slide on this here in a second, with order of placement for kids who do need to come into state custody. So like I said, your PSC, our main goal is to remain safely at home and the case is resolved. PSS, remain safely at home and court determines case can be resolved and closed. Our SCF, so these are the acronyms you may hear when you're working with someone in child welfare. SCF is our foster care code. It stands for substitute care foster. It's not a real sentence, but it's a code for how placements get open in our computer system. But really the main goal for most of our removal cases on an initial removal would be reunification to the home. If they cannot safely return to the parents that they were removed from, we will always go in the order of non-custodial parents. So if they were in a 2-parent divided household, non-custodial parent is always the first choice. Second then is legal relative that they have an established relationship with, or if they're a new baby, it would be a close relative. Family friend becomes next. They can get licensed as a placement for children as well. And then we look at our foster homes. And then if the child has a need that exceeds a traditional foster home, we have our proctor and residential spectrum of services for kids with high complex needs. At the end of those cases, if they can't go home, we do support adoption as the primary goal. However, guardianship, permanent custody and guardianship is an option for relatives and non-relative placements. For youth that are over the age of 15 who do not wish to be adopted, they can go into what's called an individualized permanency or independent living setting. And that is what has historically been referred to as aging out of the system. We've done a lot of work in the last decade to really robustly wrap those children who are aging out with services so they do not have the outcomes that you see on the news of homelessness. However, they do still have, even with the more robust service, children who age out of the system untethered to other adults struggle. Anybody on this call who has adult children knows that it didn't like magically, your child didn't turn 18 and stop needing you. The system does leave when they turn 18, or in some cases up to 21, but that doesn't give them a place to go to Thanksgiving, or a place to wash laundry, or someone to help keep them on their insurance for dental care till they're 26, as per our other conversation. So we do know that children who do age out independently tend to still have more struggles, because this world is harsh to be an island by yourself. There's my shameless plug for anyone interested in adopting older teenagers. Ongoing services for DCFS. Again, philosophy is remain with families whenever safely possible to do so. Services that we provide are often based around parenting skills, developing safety plans, conflict resolution, broader community resources. This is where we see our substance use treatment. DCFS does not actually pay for substance use treatment. We use our local substance use authority system. So we use as an intermediary to getting them connected to substance use treatment programs. One thing we do have, lucky here in the state of Utah, is we do have 5 parent-child residential drug treatment programs. So for small children whose parents are using, like in the fetal exposure realm, we have 5 programs where a parent can discharge from the hospital with their newborn into residential drug treatment. We see huge successes with these programs. If I had my way and $1 bazillion, we would open 17 more of these. When we talk about reunification rates for kids that come into foster care on fetal exposure, when they do not enter these programs, it's about 47% reunification. The rest go to adoption. So that's less than half of the kids removed at the time of birth actually ever return to their mother. If their mother or father goes into one of these parent-child residential treatment centers, the reunification rate is 78%. So we see almost a doubling of this being a really successful way. What we see when we remove a child from a parent using substances at birth is that that parent tends to lose hope. You have a lot of emotion coming post. I mean, everybody out here knows postpartum is your hormone soup to begin with. And then we take the baby from you. We interrupt bonding. No matter how many visits we do, it's still not going to be the same. And then a lot of times that also comes with losing housing resources, losing Medicaid coverage, not having that child makes you ineligible for a lot of the services you actually need to get better. So this is one of the main focus areas when I say, how do we make our child welfare system broader than just abuse and neglect? How do we build a system that really responds to women who may be struggling with substance use and pregnant as early as possible? I'm proud to say that Utah has one of the more innovative legislations around this, meaning that we removed the mandatory reporting requirement from physicians who are working with pregnant women. So if I am a pregnant woman and I disclose to my doctor that I'm using, it used to be up until 2020, they had to put that into my file and report that at the time of delivery. Utah no longer requires you to do that, and except now it is at the time of delivery if I am still using. The goal of that is so that we can have our OBGYN community doing better screening, because that was the biggest thing to screening. They didn't want to screen because they didn't want to know, because they didn't want to have to tell. It's like, well, now how about you screen and connect to services because you don't have to tell. We took the have to tell off the table and said, how do we engage in a way that you are screening so that we can connect to treatment as much as possible? I'm not sure if all of you are familiar with Dr. Smid, but she does some really great research about how even a little bit of abstinence through pregnancy helps a lot. Every single day that we can get that use to stop, every single day that we can help remove that stigma, start to get someone healthy. The other thing that legislation changed is if they are in treatment at the time of delivery, you don't have to call DCFS either. We were responding to cases that made absolutely no sense. People that were in House of Hope or residential drug treatment, transported to the hospital to deliver, going to go back to their residential bed, nobody needs DCFS coming in and adding stress to that. That situation is already managed. We add nothing to that. And so we were able to get some of that legislative change there, so that we're only responding really when it is still out of control. And continue to look for opportunities of how do we support that mother-child dyad in a way, and fathers, again, want to keep dads in those pictures too, but how do we keep those parents, how do we keep that baby safe but still connected to those caregivers? Because when we do disrupt that bond, we do see a lot of loss of hope. We don't see the parents bonding the same way. And what we also see, unfortunately, is that if we remove a child, offer short-term reunification where the parent is unsuccessful, that parent has about a 60% chance of producing me another fetally exposed child within the next 3 years. So as a system, we're really just kind of perpetuating a problem and not intervening meaningfully. So we do try to offer services. We try to safety plan. One of the things that I get asked a lot is what's the difference between a fetal exposure that gets to go home with a parent and what doesn't? And the number one thing is, who is the support system helping that parent with a substance use problem parent the child? Because DCFS is always going to be look at who's actually meeting that infant's needs. If I'm a parent who may use and be unable to be responsive, is there someone else there? So if I have an appropriate grandmother or an appropriate aunt or a roommate or someone else who is sober, who is also living in that home, who's willing to take on part of that care of that infant, I can then safety plan around that. And that will be less likely for that child to need to come into a foster placement. If I'm a completely isolated parent with a substance use problem who won't connect to other people for support, I don't have, the child welfare system doesn't have a person to help with that parenting, and then that risk is higher, and those are the ones in which we end up taking the child into state custody. So again, shameless plug for building social connections for any families that we're working with. Any people anywhere near childbirth age, having that normalizing, having a quality support system that you can turn to is a huge predictor of keeping state agencies like myself out of your life. So that was kind of a little squirrel, but I think really relevant to the conversation for this group that we're working with. So we talked a little bit about this already, the continuum of placement. And then social connections is the second part of the protective factors that we are trying to build with families. Do any of you in your agencies use the protective factors or the Center for the Study of Social Policy or the Children's Bureau? There's actually two sets. One has 6 and one has 5, but they're very similar. Do any of your agencies utilize the protective factors framework?
I've never heard of that, so I don't think so.
Okay. I am going to send, or I will have Bailey send a link to the things. So the Center for the Study of Social Policy did a 30-year retrospective on what kept some families system involved generation after generation, and why maybe that next door neighbor in pretty much an identical situation never had system involvement. And they really boiled it down to these 5 things that I think we are doing in all kinds of systems automatically or unintentionally, maybe not all 5 of them. But it really serves as a lens for helping understand a parent's point of view and a parent's action, and how we help build them in a way that they don't come back to child welfare attention or JJYS attention. And it really starts with resilience. How is that parent actually handling the stress of parenting? Which dovetails into, who do they reach out to when you get overwhelmed? Because every parent gets overwhelmed. So who are my social connections? Who supports me? Couple big pieces on that is supports what I should be doing, not give me bad advice. And I'm actually willing to be vulnerable too. So child welfare is really good at creating these call trees or these eco maps of people. But if I would rather die than be vulnerable in front of this person, that's not a connection I'm going to use at a time of need. So when I'm struggling with something parenting. So the third one is 100% this group right here, which is looking at knowledge of parenting and child development and really normalizing that every parent hits a teachable moment. We all hit a place where what we know or understand about parenting doesn't work or never did work. Maybe it's a generational thing. Maybe it's that I have a child with a special need that is different than any of my other children or any of my friends' children. And so I'm looking for a good place to get quality advice. It also is really encouraging that not using children as measuring sticks or comparing back and forth. I am totally guilty of that. I have Irish twins. They're 14 months apart, and they could not have been developmentally more different. For neurotypical children, I had one that was born like ready to run, like freaked everybody out in the delivery room because she was making direct eye contact, did not go to sleep, just stared at everybody for the first like 3 hours of her life. Like she looked like she was going to scream at you, like had something to say. She crawled like an inchworm on her head before she had enough motor function to actually crawl normally. She walked early, talked early, all those sort of things. So then my little girl that was doing things like a normal baby would, I kept taking to the doctor. I'm like, she's not doing this, she's not doing that. And finally the doctor looked at me and was like, yeah, that's because you keep expecting her to be like the weird one. The weird one, you just had the weird one first. I was like, oh, okay, cool. And to this day now, my one that took her time and did it on schedule is way more coordinated than the one that tried to run like a baby giraffe. So there you go. But it's about helping with those measures. This is one that we also see when we're talking about kids who have experienced trauma or who maybe have been fetally exposed. So helping with those expectations for development and really making sure that we're connecting to quality resources. 4 is, again, just more evidence that Maslow knew what he was talking about. It's just a reminder as helping agencies to start at that food, clothing, shelter, security, that a lot of times the behaviors that we are maybe clinicalizing or putting up at the top of that pyramid may have an explanation in some of that. Am I getting enough sleep? Do I have a safe place to stay? Have I eaten today? Do I have feeding issues? Like really looking at some of those just as a reminder, because I think a lot of times, especially for child welfare, we want to throw therapy at everything. And maybe we need to back up a little bit and we need to make sure that we have those base pieces so that I can focus and concentrate in therapy. And then the 5th one is the social emotional competence of the children. So how are the children learning age appropriate emotional regulation? Are they being soothed the way that they need to? Are they learning how to make a mistake and have the sky not fall? Are they learning how to feel bad and how to feel better after feeling bad instead of just avoiding ever having to feel bad? And these 5 protective factors, there's a ton of research on them, a ton of handouts, there's a survey that you can do with families for it, and they're really a great lens. I know that like, I'm blanking on the name. What is Barb Levitt's group? United Way has a lot of resources on the protective factors as well. So if you ever want any more information about them, please let me know. But this is one of the lenses DCFS uses. So actually our closure statements for our CPS investigations and all of our ongoing services assess and build these 5 protective factors. All right, how am I doing on time, Curt? I don't want to eat your time.
You still have like 5-10 minutes.
Okay, cool. All right. And then we have our best practices for foster care. We have our child and family teams. So anytime that we are having to put a child outside of their family, we want to include the biological family, the extended family, and the placement family together into our child and family team. If you are a service provider working with a family with DCFS, I saw a lot of yeses. Have any of you ever been invited to a child and family team meeting? I'm seeing some head nods. That's good news. Know that you should be. If you have not been, definitely feel empowered to ask to be, but I'm seeing good yeses, which makes me very happy. That teaming process really should be about getting everybody on the same page, making sure that we're intervening in the least restrictive but best supportive way possible. We do talk about timeframes for permanency. So there is a federal clock that starts when a child comes into care. There's a lot of debate. We could do a whole session debating the pros and cons of a time frame. As of right now, a family has 1 year to alleviate the reasons why their children was brought into foster care. They have the ability to have up to 6 months of extensions. They actually have to be granted at 3 months at a time. And there's a different standard of evidence of progress that has to be presented at each of those hearings to get to that extension. When I'm sitting in my world of people who are in addiction studies, they get real queasy at 18 months. 18 months can seem really long when you're talking about a little newborn baby. When you're talking in the world of addiction recovery, that's not a huge time. And so you're kind of in this weird balancing act of right and wrong for what could determine the next 18 to 30 years of a person's life. And so that is why we want to have those meetings. We want to be having those conversations, and we want to be supporting whatever direction we can get to as collaboratively as possible. So there is always a primary goal which is set. Like I said, 9 times out of 10, that is going to be reunification, unless there's some very specific and statute reasons why we do not offer reunification. They are pretty, we'll save you the PTSD, but they're pretty traumatic reasons why it would automatically go to no reunification. We can offer no reunification if this is, multiple times that you've had child welfare involvement, which this is another hot button discussion we could have for a while. So for women who have had multiple children removed for fetal exposure, some areas will go straight to no reunification. I personally fall on the give it a try every time because of the data we have to say they're just going to get pregnant again. I would prefer to keep hitting my head against that brick wall as many times. Maybe one time the door will open and we will get some sobriety. It just bodes well, especially as long as they stay in childbirthing age, to continue to try to reach out and offer treatment. Concurrent goal can be adopt. Most of the time with little kids, you are going to see it as adoption. This is a very interesting time for us because there is now some national pushback, especially if the relative is who's going to be taking permanent custody and guardianship. The language for termination of parental rights includes strictly necessary. So if I am grandma and I am going to adopt my grandchildren, I could make an argument that it is not strictly necessary for me to terminate my daughter's rights. Just give me permanent custody and maybe in 10 years, she'll turn her life around. So right now it's always adoption. That is being actually fought out in the Utah Supreme Court right now as to whether or not for kinship adoptions, termination is always strictly necessary. If the parents' rights have been terminated, they can be reinstated. The parent themselves has to get an attorney and file, and you have to show fairly significant change, and the state also has to agree. So the only time you'll see parental right reinstatement or reinstatements typically are for maybe some of our teenagers. So one of kind of the sad sides of foster care and adoption is that we do have a very large population of post-adopt children who actually come back into DCFS care based on behaviors as a teenager. And it's, that's again a whole other discussion as to how or what leads to their but sometimes those youth we have trouble finding another home for, and we have explored reinstating rights of parents that maybe lost rights 10 years earlier and are in a different situation. Also, if we reinstate those rights, sometimes that allows us to explore some other kinship options that maybe weren't explored at that initial adoption 10 years previous. So that was a whole lot of information about a complicated system that has tons of nuances. I appreciate your time and attention on it. And if you have any questions or anything else moving forward, if you ever have cases that you want to staff, I am here to do that for you. Me and my team here at the state office are always willing to staff situations and really look for those systemic solutions. Also, like I said, if you have a vision for how we can be a more inclusive child welfare system that doesn't wait for abuse and neglect, I would love, 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 love to be part of those conversations with you as well.
Awesome. Thank you so much, Kyla. That was a really amazing presentation and a lot of good information that I think everyone appreciated. Does anyone have any questions or comments or ideas? We have a couple minutes that you can ask Kyla. Or, oh, Tressa asked. Oh, never mind. You saw it. She asked what the email was.
And I will take the last 2 minutes to say we are desperately in need of foster placements. We're desperately in need of treatment providers wanting to work with our kids, especially our more complex kids. So we are always recruiting. We're always open to feedback on why people are hesitant to work with us. I know that this has been kind of a balance, again, sort of a rock and a hard place, where as we've continued to push towards this family involvement and family connection, sometimes that can feel like we're devaluing the foster homes that come in. We definitely will have children who do not have family that they can go to, we do need great foster parents. And we are seeing some great results from foster parents who do maintain a relationship with parents. So there's a whole series that Utah Foster Care just put out on YouTube of sharing stories of foster parents creating that relationship with the natural family and how you're kind of just creating this village to support this young person. What we know is that young children can't have too much love. There's no way to have too many caregivers, too many adults who love and look out for a child. And so as we continue to try to recruit foster parents, any insight that you guys have, we're open to hearing. I'm in a new role for all kinds of service array stuff, so my ears are wide open as I'm learning. So please reach out and let me know your thoughts, and we'll build something beautiful. And I think Nancy kept unmuting. Maybe you were going to say something and then I just kept interrupting.
Yeah, I have a question. I worked with a kiddo that our company actually did refer to you guys. And then the family blamed specifically me. I did not make the phone call, but they blamed me for it. Do the families ever find out who makes that phone call?
No, so we do not tell them who the referent is. We're actually legally not allowed to. They often will, what we find is I'll actually get calls from multiple people because they'll kind of splatter paint the wall of like, well, it could have been them, it could have been them, it could have been them. And they kind of have that conversation with multiple people. But no, by law, we do not tell them who the referent is. And even if they were to do like a government records request, that information is redacted.
Good question. Are there any other questions for Kyla? And she did put her email in the chat, so if you do have any ideas or questions later, you can email that. And we will be putting those slides, because there was a lot of good information on there. We'll be putting those slides on the Canvas page. So again, if you don't have access to that, email us or message us right now and we can help you get that so that you can access that. If there's no questions or comments, we're gonna go ahead and move on to our case presentation. Thanks again, Kyla. We really appreciate it. So Curt is gonna be giving our case presentation today. So I will go ahead and share the screen for you, Curt, and then turn the time over to you.
Perfect. Thanks. Thanks, Bailey. You'll notice that Janelle's not here. She's presenting at a conference today, so I can excuse her from being here today. I just wanted, emphasize as we get started here how important the survey is. I know Bailey put it in a little while ago in that chat. Hats off to Janelle and the ECHO team, I guess, here. We were funded by DHHS on a fairly decent sized grant to be able to do education and personnel development throughout the state of Utah around mental health and substance abuse. And we're using the ECHO model to do that. And I'm confident that a big part of that is because of the feedback that we get through these surveys. I've said all along, early on in the first and second year of ECHO, how critical that data is, that when it comes in and people are learning and it's appreciated. When we wrote the proposal for this grant, we included a lot of the data that we've gathered through both the scope ECHO and for those of you that are dual ECHO with us, the early ECHO. And so just wanted to pitch again that survey. If you have a quick minute, it's not too many questions. It really helps us in being able to get continued funding for these type of projects. And we are currently expanding quite a bit with the ECHO. We've got some other ECHOs that will be also starting. So we're gonna expand, and our roles are changing because we've got enough funding to be able to do these ECHOs. So thank you to those of you that do the survey. If you haven't done it before, it's relatively quick and easy. I'd love to have you take care of that for us. Okay, go ahead, Bailey. Go ahead and pull up the slides. And I will say this is a kiddo that I believe is from the Upper 3 program. It's one that Janelle had worked with in the past. She's not here to present, so she asked me to present. And I'm not sure, Bailey, if we're going to jump into small groups or not, but at the end, we do have a couple of questions that we'd like you to answer as we go through. So go ahead and push to the next one. So just give a little background on this case. It's a 3-year-old little girl who attends daycare that utilizes a curriculum. So it's a structured daycare. She attends 4 hours each day, Monday through Thursday. There's 9 other kids and 3 adults. So it's a good teacher to child ratio. She is very emotional, needs ongoing assurance and hugs, or some type of a physical touch, a hug, holding a hand, patting on the back to kind of help her stay somewhat organized. She has a diagnosis of trauma and stressor-related disorder, currently in a kinship home in the care of the county. There is a history of neglect and maternal substance use in her. There was also the death of her newborn sibling. So she had a sibling that died at the time they were born. Go into the next one there. The child struggles with any kind of transitions between locations or people or that. She'll scream and yell and become dysregulated. She also will just randomly scream throughout the day. She struggles with participating in the class activities and is often dysregulated. And that's one of the reasons she struggles with those attending to those activities. She'll run around and wander off. A lot of times needs that one-on-one support to keep her in the area she's in. When she's unable to get her way, she becomes frustrated. She'll start to hit, kick, and scream with caregivers, other children, and that sort of thing. She does struggle to engage with peers, and keeping in mind she's 3, so she should be starting to be doing some engagement with peers rather than just the parallel play. When she can focus and sustain her attention, she can participate in the activities, but that's fairly uncommon from what Janelle said. Her speech is at an age-appropriate level. She currently doesn't need any speech services. When she speaks, she's intelligible. She can be understood. Go to the next slide, Bailey. So she does receive individualized therapy once a week. And if she needs more, she gets more. I believe that she was probably in an ABC class or something of that matter, autism-based instruction class when she was younger. There is a mental health clinician in the class with her every day, assisting with the behaviors and providing interventions. She received occupational and physical therapy services weekly. She uses the visual schedules, that's her primary, and then boards and timers are also being utilized to try to keep her on task. There is a safe place in the classroom that she can utilize to help herself calm down. And so you see from the preschool that she is in a structured environment with the curriculum that they use. Next one, Bailey. So the goals for the child are to transition is to be able to transition appropriately and to use her words to vocalize her wants and needs rather than yelling and screaming. She's really smart. She can tell you the colors of the rainbow in order, tell you her name, how to spell her name, identify colors and shapes. She's currently learning how to read books and sight words, currently on a 5-year-old education level, even though she's only 3 years old. She had a hearing screening done recently, which she passed. We know her hearing, and that's good. And here's the last slide, is with regard to the discussion, what we want to discuss in our group or groups today. So these are the things to look at. How do we better support her in the classroom? And I wish I had better background on this so I could tell you exactly what the curriculum was or what the structure looked like. But we do know it was essentially three adults to 10 children, and that there is some curriculum, some structure there. What new interventions can we try? Keeping in mind we've had physical occupational therapy, mental health therapist or counselor, clinician, working with her on social skills and modeling. And then also, would referring a psychological evaluation be appropriate? And if so, any recommendations of who and where? And obviously, those of you that aren't in Cache Valley, there may be some down in Salt Lake or Ogden or wherever you might be that could be helpful. So Bailey, I'm not sure if we're going into one group or we're going to go into multiple groups. Any questions that I might be able to answer from the group here before we go into groups? Okay.
Does anyone have?
I'm
You're
not
done?
as good at waiting like Janelle. Janelle will wait like a whole 20 seconds. I think that's what she says. I'm like, after 5 seconds, I'm like, okay, somebody's got to say something. So.
Okay. Well, if there are no questions, feel free to interrupt me if you do have one. But we're gonna go ahead and just do 2 like smaller breakout groups, medium size. And we'll split up the questions. So Curt, your name's at the top of my list. So whoever's in Curt's group, and there is another hub member, I think, in there with you. But you guys are going to talk about the first question, how to better support this child in the classroom. And then if you have time, also talk about the third question, which is, would referring for a psychological evaluation be appropriate? And then, oh, I lost my screen. The second group is going to be Kyla. If you guys could talk about the second question, which is new interventions they can try. And then also, again, if you have time, do the third question of if a psychological evaluation is appropriate. So I left that up so you guys can screenshot if you need to. But I'm going to go ahead and open those rooms and then go ahead and join. And I'll bring everyone back around 1:20. That way we can talk about it. So have a great breakout session. Okay, so welcome back, everyone. Thanks. I hope you guys had good discussions, and we're going to go ahead and we have like 10 minutes, but we're going to just kind of share some of the things that you guys talked about. So I don't know which group wants to go first. Curt, will you go first? You're first on my screen.
Sure. Let me just pull up my notes here. So we had the question, and my group, feel free to jump in anytime. We had the question about how do we better support in the classroom. Megan gave some really good insight. She used to be a teacher before she became a service coordinator. She said that she found that giving children specific jobs would keep them focused. So as they start heading into that dysregulation state, that they would have the job to go and to take the crayons or to sharpen pencils or whatever. And obviously it'd have to be catered to a 3-year-old or 4-year-old, however old this kiddo is, but that they could go focus on that task, and focusing on that task would sometimes help with that. We also asked what the picture schedules look like. Are they the type of picture schedules that have an actual photograph of that child eating lunch or taking care of the trash or whatever the case is, or is it just the clip art? And we all know that the more realistic it is, them versus clip art, the better it is. Pat asked about a therapy dog and whether that'd be beneficial for this child to help regulate them or help prevent dysregulation. Also, we had a question about psychological evaluation, and the questions we asked about that were, what would we be looking for? What would we hope to find out by psychological evaluations? Are we looking for signs of abuse? Are we looking for autism? Are we looking for other emotional challenges? And then we know that transitions are difficult. So would the evaluator get a true picture of what the child's like, or would that transition of having them come to the office, or even if it's in the classroom, having another person there, would it skew the results of that evaluation? So that kind of sums it up, unless someone else has something else to say.
Okay, I'm gonna assume not. So thanks, Curt. Kyla, who from your group took notes and wants to talk?
So I took some notes. We had some really great discussion about things that we could give to this child. Talked about like maybe a backpack with fidgets. We also talked about how talking about a class of 3-year-olds, so something that doesn't create jealousy. Transition songs can be really helpful. In a past life, I used to work with 2.5, 3-year-olds. And so things like the hokey pokey, where you can change the words to talk about feelings or what I'm about to do next. So along with that picture schedule, but really kind of these musical pieces that mean something else is going to happen. I love that combined with like having a job or having a movement that we all do. We talked about maybe like a stuffed animal or something that they could clutch. We also agreed that the evaluation would make sense, but wanting to kind of target what we were looking at, particularly any sort of trauma. Like, what do we know about what this little girl has witnessed that might explain why some of this separation or this need for touch exists, and so that we can account for that as we talk about how we intervene. So we did see some good purpose in that assessment as well. Anything else we talked about, Nancy or Erica, that I missed, or Emily?
We kind of talked a little bit too about the timers. Is it like at the front of the class so it's for everybody to see, or would a timer right in front of her help so that she can look at it right there and go, oh, okay, it's almost time for us to move again?
That's awesome. Awesome suggestions. Thank you. So if you can just, Kyla and Curt, send those notes to me, I will forward them to Becky and she can, I saw yours, Curt, I think.
I was going to say, already done.
You're on top of it.
I also gave Kyla a website to go to that you can find professional help, psychologists in your area for specific age groups and whatever insurance you've got. You just enter that all into the website and it'll pull up the therapists in your area.
That's awesome. That is a very handy tool to have for anyone, like whether it's for kids or not, but just to be able to find that. Do you mind sharing that just in the chat too? So that
yeah, it's Psychology Today. But I'll put it in the chat also. It's actually how I found my psychologist.
awesome. Perfect. Okay. Well, and like I've said before, all the notes in Kyla's presentation, they'll all be on Canvas. So if you want to go see what any of those other resources are or suggestions, that is a great way to do it. And I'll put it in one more time, the link to the survey. I'm going to let you guys out 4 minutes early, and give you back some of your Wednesday. But please take that survey. Like Curt said, it is really beneficial and it helps us make these better, and it's helped us get the grant, which is just helping us address all the important topics that we deal with. So have a great day and thanks again for attending. Bye.